its growing time, there is always a fantasy to start with a new approach. It has got its own pros and cons. But we need to learn that, because sometimes when your ambitions supersedes your performance, then gap is called frustration. But if you reverse it, when your performance exceeds your ambition, then it has got success. And that's why we need to learn the direct anterior approach also. It's very well required, and sometimes we are destined to do that. For that, we are starting a new session. Dr. Vijay?
Yeah, so I think this is a very important session for people who want to learn direct anterior approach, or maybe have an insight into it, and very nicely structured session. So without further ado, I would like to invite Dr. Manav Luthra, Dr. Mudit Khanna, and Dr. Palash Gupta, if they are around, and Dr. Shubhankar Shekhar Shubhankar has been with us, and he has seen a lot of direct anterior approach, so he's going to tell you about the basic steps, patient selection, and surgical techniques.
I'm so honored to have both my professors, both my teachers as my moderators today. So we'll begin with DA 101. I'll be covering the basics today. So there are no disclosures. This is the case I present to you with. So this is in one of the this is one of the earliest cases I operated as a primary surgeon, and this shows a failed FNS done elsewhere. Now we step by step approach the case. So the history for direct anterior is a pretty long one associated with many prominent names. Why are we shifting to the direct anterior approach? So in a nutshell, it is less concerning for the surgeon, more beneficial for the patient. So is there a learning curve? Yes, there is definitely a learning curve for all surgeons shifting from posterior to anterior. For trainees who've trained in direct anterior, there is not much of a learning curve, as is evident in the literature. Patient selection in the initial few cases is necessary. So in a nutshell, you should be favoring the patient on the left, avoiding the patient on the right in the initial few years, though you should be accepting all patients. That's the goal. So we'll talk about the concept of working space. What do I mean by working space? Have a look at the X-ray on the left. So you can see that the neck is short, the horizontal offset and the neck shaft angle is low, and therefore the distance between the ASIs and the GT is low. So this is going to be a tough case. You're going to need a lot of releases, probably complete iliofemoral followed by conjoint for this femoral delivery. So we are all aware of the approaches, the intervals. So always plan. Your planning is straightforward. You should be ready with plan B contingencies, which include improved knowledge of improved exposure, backup implantation, wires, cables, and fluoro. Well, frankly, armamentarium, the very first few cases I did were with posterior instrumentation. I graduated because as I've matured with femoral releases, I've come to realize that shorter incisions, less releases lead to better patient outcomes. So I've started using these instrumentation. I've matured from a normal table to a traction table. Implant choice, frankly, any implant can be done, including your S-ROMs. But yes, literature states that there is less subsidence with colloid implants. Patient positioning. Every table is the best table. So if you're using a normal table which gives you a break, you have to ensure that the hip is at the edge of the table and that the break is at the level of the GT. Same goes with the fracture table, but just that you have to ensure that the femur hangs by the side and that you have something to elevate the femur. This is my iteration of it. I've gone through all the tables. I find this very easy. Drape the patient. Do a pre-incision fluoro. You should be recreating the standing AP pelvis. Image both hips once. Your skin incision depends upon what kind of table you're using. It has to be a more lateral skin incision if you're using a normal table. It can be more in line with the ASIs, and an oblique incision if you're using a fracture table. Split the fascia, dissect the muscle belly, find the interval, cauterize the LCFA, release the reflected head of the rectus and raise the iliocapsularis. Now, you have to do a capsulotomy. Many surgeons favor an H capsulotomy. I personally favor an inverted capsulotomy. I personally release the pubofemoral ligament early on because I'm doing it on a fracture table and it helps me with external rotation, thereby mobilizing the napkin ring cut, and it also helps me in posterior displacement of the femur once I apply the posterior retractor on the posterior wall of the acetabulum. So remove the napkin ring cut, extract the head. Once you've cleaned the acetabulum well, you've applied all your retractors, your anterior retractors, your posterior retractors, you ream the acetabulum under fluoro, impact the cup and the liner. Now, what is essential is that you release the iliofemoral ligament. If you're not releasing the iliofemoral ligament, you're bound to end up with complications, you're bound to end up with struggle. So, release the iliofemoral ligament. If needed, release the posterior capsule. So, the easiest way to go through it is take the tip of your electrocautery or bovie, feel for the tip of the GT, do a diagonal release. If needed, recess the complete superior capsule because that is also part of the iliofemoral. Once you've delivered the femur, assess for lateral excursion. Do sequential releases. I pointed out the conjoint here. If needed, you can release the conjoint. Start broaching and trial. I sincerely suggest that now it's more of a compaction broaching rather than extraction. So I would recommend rather than for going for a box cut, use special instrumentation such as this reverse curate or chili that's available. It has reverse curating teeth and helps with getting more lateralization and a little posterior superior entry. Once you're done with the final broach, reduce, do a shuck. So this shuck is possible with the contraption I've made with my fracture table. I'll talk about it later if there is time. Do a reduction, check for your femoral stem in both and AP and lateral views so that you know that you're not perforating the posterior or the lateral cortex. Close the capsule if you're preserving the capsule, close the fascia, close the skin, and you're done for the day. So this is the outcome the patient walks normally by the time he comes for stitch removal on the 14th day. He can squat, he can sit cross-legged. Now there are certain points to emphasize which I'll emphasize very quickly. Pick your cases, don't struggle, be aware of the anatomy, the orientation and the planes, find the correct femoral entry, beware of the red dragon, the MCFA, have a contingency in place, reset. Do a hard reset every time you feel that you're having trouble delivering the femur. Use tranexamic acid both preoperatively, intraoperatively, and postoperatively. The new studies coming up show that you can give 650 mg of tranexamic acid orally for next 3 days. And never stop learning. Keep attending courses like Kanpur Arthroplasty course and CCA at my institution for brilliant workshops and brilliant lectures. Try until you succeed. Thank you.
Thank you, Shubhankar. We'll have the questions at the end. So